Hello class, this is Professor Edwards-Diaz with your lecture on care of the patient with a traumatic brain injury. In this lecture, we're going to review the etiology, pathophysiology, and classification of traumatic brain injuries. We're going to cover nursing assessments and interventions related to TBI diagnoses and monitoring, complications of TBI, the nursing process in caring for patients with a TBI, factors related to caring for TBI patients and their families, and some long-term needs of patients living with a TBI. Traumatic brain injuries are more common than we think. They have a significant social impact and a huge impact on the individual who sustains one of these injuries. We don't really know how many people sustain a traumatic brain injury in any given year because it's estimated that a number of people who have a blow to the head don't have severe symptoms, so they might not ever seek care, and then they recover from it. In the United States, at least 1.7 million people a year sustain at least a very mild TBI that would require a person to seek care. About 250,000 victims of TBI will need hospitalization for moderate to severe TBIs, and approximately 52,000 will die from their injury. For those who survive a TBI, there can be severe impacts on their lives. They can have emotional and cognitive changes, various physical or sensory deficits related to either the initial injury or complications that develop after the initial injury. And there's another type of brain injury that will not be part of this lecture, but they're worth mentioning. A stroke, for example, also called a cerebral vascular accident or CVA, sometimes you might hear them called brain attack, is also considered an acquired brain injury, whether it's ischemic or hemorrhagic. Stroke and TBI possess a similar clinical presentation and can have very similar symptoms. However, the basic goal for both of these types of injuries is to prevent increases in the intracranial pressure. The big difference between the two, traumatic brain injury, is from an external force that causes the damage, and this can be either from a direct blow or strike to the head, or from a high energy force that causes the brain to shift inside the skull. The primary injury occurs right at the time of the initial injury. Typically, a strike to the head would be considered a primary injury. The secondary injury occurs after the initial injury and is typically related to an increase in the intracranial pressure, or a hemorrhage that could cause a person to be extremely hypotensive to the point that the brain suffers because it does not get enough oxygen for a period of time. TBIs are not always caused by a strike or a blow to the head, but they could be from projectiles that penetrate the skull, like bullets from gunshots, or shrapnel from an explosion, or from a skull fracture that is not intact where the skull can penetrate part of the brain. The terms used in traumatic brain injury are quite similar to the ones that we use in musculoskeletal trauma. You can have an open or a closed injury. So open injuries occur less often, and they're serious. Most brain injuries are closed head injuries, meaning that the skull stays intact, but those injuries are often more serious. We also classify TBIs as either direct or indirect. So again, the direct injury is from the initial strike to the head, and the indirect injury is the movement of the brain in response to that outside force. A common type of injury we often see is called the coup and contra coup injury. So on this slide, you can see the movement of the head due to an outside force. The coup injury is where there is an initial impact, or the initial damage, as the brain shifts and strikes the interior of the skull. In this picture, the brain shifts forward and strikes the front portion of the skull, as seen here. The contra-coup injury occurs when the head recoils back, causing the brain to shift and strike a portion of the brain opposite of the initial injury. So in this picture, the head recoils back, forcing the brain to shift back and strike the back portion of the skull. Another mechanism of injury is called the acceleration-deceleration injury. Now, using this same picture, imagine someone is driving and is rear-ended in their car at a high speed, or someone drives into something at a high speed. They might have their seatbelt on, or we hope that they do, but their head doesn't strike against anything. They can still sustain an injury because of the movement of the brain. It's not always just a back and forth movement of the brain, but the impact can cause the brain and the nerve cells within the brain to twist on the brainstem. So not just a back and forth or side to side, but there can also be twisting movements that can have a shearing effect on the brain structures. An epidural hematoma is a collection of blood between the skull and the dura. This is a medical emergency because a patient's intracranial pressure will increase very quickly. Epidural hematomas are tricky. People can have a brief loss of consciousness, sometimes regain consciousness and alertness, so they would have a lucid state temporarily. But as the hematoma grows rapidly, the patient could have a sudden decline in their level of consciousness. And the reason why this happens is because an epidural hematoma is usually an arterial bleed. So there's going to be a sudden blood loss and the collection of the hematoma in the brain that is putting pressure on other parts of the brain tissue. Typically, emergent surgical interventions are necessary to reduce the intracranial pressure. Sometimes we don't wait to do this, and in an OR, depending on the patient situation. This might be done in the emergency department by a neurosurgeon who will go through the skull with instruments after imaging so they can localize the hematoma and attempt to drain the hematoma to take pressure off the brain immediately. Another common serious head injury is a subdural hematoma. We just went over the epidural hematoma, and that was above the dura. So a subdural hematoma is going to be underneath the dura. And this is going to affect the brain tissue. However, what makes a subdural hematoma different is that it's almost always a venous bleed, or so a bleed from a vein. So sometimes it's a very slow bleed that could take a while, like days or even weeks for the injury to become apparent. And they can be either acute, subacute, or chronic. In an acute subdural hematoma, the symptoms develop over 1 to 2 days. Subacute can take up to 2 weeks, and the chronic form can develop over weeks to months with fluctuating clinical signs and symptoms. But once a chronic subdural hematoma is severe enough that it's diagnosed, and there will likely be a delay in the diagnosis, but once it's diagnosed that there's a collection of blood in the brain, then that has to be evacuated either by a craniotomy, going right into the brain, or sometimes they can do a procedure called a craniectomy, where they remove a portion of the skull to make room for the tissue to re-expand, with the goal to evacuate the hematoma, or the clot, the same way they do in an epidural hematoma. And something to think about when it comes to subdural hematomas, sometimes we see patients in the emergency department immediately after their injury, and they might be fine because they don't exhibit any neurological deficits. These patients might appear to have a mild concussion, maybe have a mild headache, but they don't have any neurodeficits. But we do imaging, CT scan of the head and the cervical spine, and it might come back negative. Keep in mind that a subdural is typically a venous bleed, so it would be slow. So sometimes we discharge these patients, and in a day or two, they might start having neurosymptoms like changes in their level of consciousness or changes in their vision or a worsening headache that does not improve with any intervention. So after a period of time, that person hopefully follows up, and then at some point they would likely be imaged again, and the scan would reveal a subdural hematoma that requires treatment. A subarachnoid hematoma is a collection of blood in the subarachnoid space, as seen right here. And it's between the pia mater, the inner layer, and the arachnoid mater, the middle layer of the tissues covering the brain. A subarachnoid hematoma can be from head trauma, but the more common cause is from an aneurysm rupture. A subarachnoid hematoma is a life-threatening emergency. It commonly presents as a thunderclap headache, which patients might describe as the worst headache of my life. Intracranial pressure will increase with continued bleeding, so it's important that this patient gets treatment, and the goal here is to decrease that ICP in order to stabilize the patient well enough so they can have an endovascular embolization. Another type of brain injury that is not as common from trauma, but it's possible, is the intracerebral hematoma right here inside the brain. And this is a bleed that starts deeper into the brain, so not close to the dura at all. And This is the same kind of thing that can happen with like a hemorrhagic stroke or with an aneurysm rupture. So the hematoma forms in the more interior part of the brain, and this requires aggressive treatment to evacuate the clot and prevent the intracranial pressure from rising to the point that the brain tissue starts to die off. The last injury to present is the diffuse axonal injury. These are more indirect injuries that typically don't involve a direct blow to the head, but they involve acceleration and deceleration, or coup and contra-coup injuries. When there is a movement of the brain inside the skull, there can be some twisting movements that can cause widespread damage to the nerves in the brain cells. And this can occur even with a mild TBI. When assessing a patient with a traumatic brain injury, the first thing to do is to really try to get an accurate history of the event. This could be challenging because even with a mild brain injury, a patient could be confused. And that's a cause for concern because the patient is exhibiting a neurologic symptom. They might not be able to recall what they were doing immediately before the injury, like a transient amnesia about the event, and that's not unusual. So it's important to ask witnesses, ask family members, first responders, or whomever was present or involved as to what happened to this patient. It's especially important to know if the patient lost consciousness. The duration of time spent in an unconscious state is one way for us to classify the severity of a TBI. Mild is under 30 minutes of LOC, moderate is 30 minutes to 6 hours, and severe LOC is over 6 hours. However, people can still have a mild brain injury without LOC, so it doesn't exclude an injury, but it's helpful to know the duration of the LOC. Also, it's important to assess if the patient was under the influence of alcohol, drugs, or both, because this will have an effect on the assessment, like in the pupillary response, reflexes, or with the respiratory rate. So all of this information is helpful to know. TBI has been associated with acute alcohol intoxication, and most studies estimate that between 30 to 50% of patients treated for a TBI were intoxicated at the time of injury. Of course, we want to know about any allergies, prescribed medications, or chronic conditions. We want to know the patient's baseline cognition, and this would be especially important if you have an older person who might have a history of cognitive changes like dementia, and this is information that could come from a caregiver or a family member. Assessing the baseline cognition on arrival is important so we can determine if there are any changes in the future assessments. Keep in mind that someone in a trauma situation can have multiple injuries. They can be internal, like brain injuries, so they're not very obvious, and they can be more obvious injuries like deformed limbs or open fractures. But in these situations, you need to prioritize airway, breathing, and circulation first. You also want to consider the potential for spinal cord injury. Anyone who's had a physical trauma that could injure the brain could easily have a cervical spine injury, so they will likely have C-spine precautions in place, and along with a cervical collar. Remember that in the emergency department, these precautions are cleared by a physician, so that collar remains in place until then. Next, assess for mobility and sensory perception. Can the patient move their toes, fingers? Can they feel you touching them? Monitor vital signs frequently, and remember to assess their level of consciousness and continue to reassess. In terms of brain injury or assessing brain injury, the level of consciousness is the most important assessment. A change in the level of consciousness, especially a decrease in someone's level of consciousness, is usually the first sign that the patient is deteriorating. Some of these signs can be subtle, like a change in behavior, when a patient can seem more irritable, or someone who is familiar with the patient, like a family member, reports that the patient is not acting like they normally would, or someone who is really sleepy and not easily awakened. Assess for pupillary changes. Obtain a baseline. The ideal is that the patient's pupils are equal in size, round, and reactive to light. Also, consider any medications or drugs that could affect pupillary response. Alcohol can cause pupils to dilate, so can cocaine. Opioids can constrict the pupils, which can make a neuro assessment more challenging. But still, obtaining the initial assessment is important because any worsening changes like unequal pupils or sluggish to no reaction to light is typically a neurologic emergency. Further assessment involves the potential for cerebrospinal fluid leak. Cerebrospinal fluid is a clear, thin liquid, and this often involves someone who sustained a basilar skull fracture. So this would involve fractures at the base of the skull, involving the temporal bone, occipital bone, sphenoid bone, and or the ethmoid bone. A fracture in one or more of these bones could cause a CSF leak that would manifest as a clear discharge from either the nose or from the ear. The use of the halo sign, right over here, has been historically taught to help detect a CSF leak. And this is where thin bloody discharge from the ear or nose is dropped on a piece of gauze paper, and it's believed that the cerebrospinal fluid spreads out, leaving a darker circle in the middle that is mostly blood, and the lighter colored circle around the darker circle is the CSF. This test is not the most sensitive or specific, but you might read about it in textbooks. Cerebrospinal fluid typically has glucose in it, so you might see fluid that is tested for that. There are typical bruising patterns that could indicate skull fractures, and these include raccoon eyes, which is these bruising around the eyes right here, and battle signs, which is bruising behind the ear. These signs typically manifest later, like 1 to 3 days after the injury. And although they can indicate skull fractures, they don't indicate where the fracture is. Increased intracranial pressure, or increased ICP, is a dangerous condition that can follow an injury to the brain. This concept of increased ICP is usually explained with the Monroe-Kelly doctrine or the Monroe-Kelly hypothesis. So the skull is a rigid enclosed space, and there are only 3 things inside. There's brain tissue, there's blood, and there is cerebrospinal fluid. And because this is such a rigid and enclosed space, a change in one has to affect the others, and there's very little room for compensation. Accommodations can be made to keep the intracranial pressure between 10 to 20 millimeters of mercury. Actually, anything above 15 is not completely normal, but it's still compatible with life. But anything above 20 millimeters of mercury can have damaging effects because the brain cells will start to die. To some extent, the cerebrospinal fluid can shift to make room for the increasing ICP, but overall, the brain's ability to compensate for increasing intracranial pressure, be it from a bleed or from swelling, is really limited. A patient's respiratory status when they're injured like this can impact the brain. So if the patient does not get enough oxygen, there's going to be cell death because the brain cells are not being oxygenated. What makes the situation worse is when the oxygen level goes down and the carbon dioxide level goes up. This increases CO2, which causes the vasculature or the blood vessels within the brain to vasodilate, and that takes up more space. You don't want the blood vessels to dilate, you want them to remain either normal or constricted. So a patient's oxygen level has to be monitored very carefully. Someone with a moderate to severe brain injury, or if they have a brain injury with a quickly deteriorating condition, is typically intubated and mechanically ventilated so that their oxygen and carbon dioxide levels could be more closely monitored. With the Monroe-Kelly hypothesis in mind, think about this. With increasing intracranial pressure, you will have decreased cerebral perfusion. There's going to be less ability of the brain tissue and the brain cells to receive blood and to receive oxygen. This will impact the brain's function. So if there's a hematoma or edema in the brain, and either of these increase, there is going to be limited space for the brain tissue. Eventually the brain tissue starts to move, and this is called herniation. For many patients, as they approach herniation, they're really approaching death. And if they come back from this point, they're likely to have neurologic deficits because they could have lost a number of functioning parts of their brain tissue. It's important to pay attention to those earlier signs and symptoms of a worsening problem. Assess for changes in the level of consciousness, pupillary changes, weakness in an extremity or one side of the body. People will often complain of a headache at the beginning of a brain injury, but anything that is becoming worse or a headache that is worsened with sneezing, coughing, or with minimal exertion could indicate a worsening condition. Late manifestations of increased intracranial pressure include an increase in systolic blood pressure with a widening pulse pressure. Pulse pressure is the systolic pressure minus the diastolic pressure. With a widening pulse pressure, the diastolic pressure will often remain the same. Sometimes it can decrease, but the systolic pressure is going to increase. So remember, the widening pulse pressure, the difference between the systolic pressure and the diastolic pressure, is going to increase. Along with that, you'll see the slowing of the heart rate, but depending on which part of the brain is injured, there can be some autonomic instability, so sometimes there can be fluctuations in the heart rate. Cushing's triad is like the body's last attempt to maintain homeostasis in the brain. You will see hypertension, and again with the widening pulse pressure, bradycardia, and irregular respirations. Other late signs of increased intracranial pressure can include projectile vomiting, further deterioration in the level of consciousness, changes in posturing, either to decorticate or disseberate posturing, changes in respiratory patterns like agonal breathing or Cheyne-Stokes respirations, and loss of brainstem reflexes. Someone at risk for increased intracranial pressure is typically monitored closely with frequent and ongoing neurologic assessments. Always obtain and keep in mind what the absolute baseline is for your patient when you assume care. This should be based on your own neuro exam and your own assessments, so that you will be able to detect those early and subtle changes that indicate that your patient's condition is worsening. Further assessments should include Glasgow Coma Scale, pupil checks, frequent vital signs, and if the patient is in the intensive care unit, intracranial pressure. In the ICU, invasive ICP monitoring is done by inserting equipment into the ventricles of the brain with the use of an intraventricular catheter. And this is the most common type of device that we would use for ICP monitoring. You see right here, that goes right into the ventricle there. Okay, so now this is inserted through a hole drilled through the skull, and the catheter is placed right into the lateral ventricle. And this can directly measure ICP, and the advantage of using an intraventricular catheter is that it can be used to drain fluid in the brain, including CSF. And with anything like this, just keep in mind that there's a high risk for infection, and it has to be monitored really closely. Frequent monitoring of respiratory status is important with patients at risk for increasing ICP. If the ICP keeps going up, they can lose their ability to protect their airway, and if that happens, they will be intubated and placed on mechanical ventilation to ensure oxygenation and to prevent hypoxia. Then they would require frequent ABGs and/or have their end-tidal carbon dioxide monitored, and oxygen saturation would be continuously monitored. Positioning is important with someone with a brain injury or with a suspected brain injury. We want to do whatever we can to increase venous return of blood into the circulation and out of the brain. And we do this by keeping the head in a neutral position, so the head would not be turned to one side, if this could be avoided, and position the head of the bed elevated at least 30 degrees. Often it's between 30 to 45 degrees if the patient's able to do that. The thought is to facilitate blood flow into the brain and then venous return from the brain. We want to avoid anything that is known to increase ICP, so avoid extreme flexion of the hips, Valsalva maneuver, abdominal distension, or any other stimuli that might increase ICP, like coughing or suctioning an intubated patient. Patients in these situations will typically be on cardiac monitoring because they can have cardiac dysrhythmias from the neurochemical changes that are taking place in the brain that can have an impact on the autonomic nervous system, and also from electrolyte abnormalities that can occur. It's also important to monitor the blood pressure for systolic hypertension with a widening pulse pressure because this is a late sign of increasing ICP. But you also don't want the pressure to be too low, otherwise this could impact the cerebral perfusion. Be sure to confirm desired blood pressure parameters and medications with the provider. We also don't want the patient with an acute brain injury to have a fever because that usually indicates a hypermetabolic state in the brain, and it's usually associated with a poor prognosis. Therapeutic hypothermia can be used, and it can be achieved with the use of physical cooling devices to cool the patient to normal thermia, because pharmacological strategies are usually ineffective. And although some facilities might use therapeutic hypothermia to bring a febrile TBI patient back to normothermia, there's not much evidence that supports the benefits of this therapy. When a patient is recovering from an acute TBI or a brain injury, it's important to maintain a quiet, calm atmosphere and to protect the patient from stress. Fluid status has to be maintained carefully, at least every hour in the acute phase, and this is one of those few instances where a patient would have an indwelling urinary catheter to accurately measure urine output. And for those patients who have invasive ICP monitoring in place, be sure to use strict aseptic technique when working with these systems. There are typical medications used when someone has an acute brain injury with an increasing intracranial pressure. One medication, mannitol, is an osmotic diuretic. It's a medication that has been used for decades, and although there is not much evidence that says it makes much of a difference, it's still ordered and it's used for increasing ICP. Now it does decrease ICP. It works by decreasing the blood viscosity so it can help to perfuse the brain, and it's designed to pull water into the vascular space and reduce the amount of extracellular fluid when there's edema. But we really see the impact of mannitol when patients have ICP monitors. And yes, it does decrease ICP, maybe temporarily, but again, the evidence that it actually improves a patient's long-term survival is really not enough to support it. Mannitol is administered IV as boluses and as an infusion, and it can be repeated as ordered. Sometimes furosemide or Lasix might be administered along with mannitol when mannitol alone is not decreasing the ICP successfully enough. Another medication indicated for increasing ICP is hypertonic saline, either 3% or 5% saline. The use of hypertonic saline is becoming more common for increasing ICP, and this is administered IV in boluses. And like mannitol, it's designed to drive fluid from the interstitial space into the intravascular space, and this decreases the ICP. Hypertonic saline has relatively similar efficacy to mannitol. Also, the studies using hypertonic saline were similar to that of mannitol, so no real evidence that either medication improves mortality. So either mannitol or hypertonic saline are indicated for increasing ICP, and either medication will help reduce ICP, but neither medication is superior over the other. The choice between them should be based on the circumstances and their availability. Opioids may be given for a patient's pain or if they're agitated, because controlling these things will help keep the ICP lower. And benzodiazepines can sometimes be used for agitation. Anti-epileptic medications are often used to prevent a seizure, and antifibrinolytic medications are used to control bleeding. As patients stabilize and are recovering from a moderate to severe traumatic brain injury, they can also have endocrine complications. Diabetes insipidus is more commonly associated with severe TBIs and often involve a basal skull fracture. Although the hypothalamus and the pituitary gland are deep in the brain, they can still be affected by brain injuries. So if someone has diabetes insipidus, it typically indicates that the hypothalamus was involved. With diabetes insipidus, the urine is not concentrated, so you'll see a very high output of dilute urine, like 300 mL to 600 mL per hour. Then the opposite can happen because of pituitary involvement, syndrome of inappropriate antidiuretic hormone, or SIADH. And this is when the body is going to hang on to fluid, so the urine output will be very low and the urine is going to be very concentrated. SIADH is the most common endocrine complication following a TBI. And with SIADH, a patient can suffer from hyponatremia because all of that fluid is being kept inside the body and it's not being excreted through the kidneys. So people will have a diluted level of sodium and their serum sodium will be really low. And low sodium levels can also impact the person's level of consciousness, lead to coma, seizures, or even death. Anyone who has suffered from a brain injury with increased intracranial pressure is likely going to have some lasting effects from it. Recovery can be quite long. Even if a patient has a really good recovery and they regain most of their pre-trauma functioning, this process can be a lifelong process. So some considerations for your patients recovering from a TBI. We want to provide a balance between sensory stimulation and quiet rest, as this promotes brain recovery. We want to monitor the patient for nutritional deficits. Brain injury results in a metabolic change that increases calorie consumption, and early initiation of nutrition has shown to improve outcomes. Parenteral nutrition through a central line or enteral feeding through a feeding tube is done until the swallowing reflex returns. Patients might have short-term memory deficits that can last for quite a while, so we reorient the patient to things like who we are, what we're doing, who they are, where they are, why they're in the hospital, the day of the week, the time, things like that. This same patient might have understood what you told them earlier in the day, but they might need to be reoriented with each encounter. Work collaboratively to have a good relationship with the family. You want to reassure the patient and the family that their concerns are being heard, and you want to keep the family updated on the plan of care. Be empathetic, be realistic. It's difficult to predict how well someone is going to recover from their brain injury, so it's important to recognize that people who have had severe brain injury will have major changes in their lives. When working with patients and families, you want to provide simple explanations of procedures. Collaborate with PT and OT to plan and maintain exercise and ADL programs. As much as possible, try to maintain a normal sleep-wake cycle. For those patients with more serious brain injuries, you want them as much as possible to sleep at night, but they will likely need periods of sleep during the day as well. We want to observe and document behavior. People who suffer brain injuries can have changes in their psychological functioning. They can have temporary and sometimes persistent personality changes. Their tolerance levels can be greatly diminished. Work with the patient and the family and collaborate with other disciplines like social work, PT, and OT to help the family understand that their loved one, who they're working to bring back home, is going to be a different person from their injuries. Make patient safety your priority. The patient might require continuous supervision and might require a sitter or the use of bed alarms. And finally, allow the family to express their emotions and provide them some support. Provide consistent information to the family. Refer the family to support groups and services and other available resources. There are a number of national organizations to help people who are recovering from brain injury, or to help family members living with someone who has sustained a brain injury. Having this kind of support can be emotionally helpful for families as they cope through these changes. Well, this concludes our lecture on the care of the patients with a traumatic brain injury. Thank you for your time today, and happy studying.